fast, Barbara. Okay,
So,
go.
Okay, hi everybody, I'm Trisha Foley. I'm one of the wound ostomy continence nurses, and I made a little makeshift wound stoma for you just because the weekend is coming and we have somebody with a wound intracutaneous fistula and an ileostomy nearby. This patient has an open abdominal wound, which is what you see outlined here. It's her wound is a little bit kind of depressed within the margins, as you can see, and then the stoma is really close, and then she has some skin creases next to the stoma. So our goal is to pouch over the wound and then also pouch over the stoma. So that's what I'm going to show you. As you can see here, she also has a drain to contend with, so I'm going to show you how to use a catheter access port in order to kind of contain and manage the drainage, because this patient has a lot of drainage. So the first step is to make a template of the wound. So that's what this is. Typically with these wound manager pouches, there's a pouch in the kit, and then there's this little plastic acrylic film that goes with it. So what I did here is I wrote skin side, because it's important to write skin side, and then I also like to write head and then toe just to orient where the template's going. So what you want to do to create a template is place your clear plastic piece skin side down, and I'm moving this as far away from the stoma as possible. And then what I'm going to do is I'm just going to outline my shape of this wound on my clear plastic template, and then you'll know exactly what size to cut your pouch out to. So that's done. It's as easy as that. So then I take my scissor and I'm going to go ahead and cut this out. Oftentimes people will misalign the template and it will be backwards, and I'm going to show you how to not do that. So again, keeping in mind that we have a skin side, what I like to do to make sure that I never have this backwards, you can see it's a very specific shape. I have my skin side, I'm putting it back down over the wound, then I take my pouch and I'm putting it over the template and I'm picking the two up together. That's how I always know that I'm not going to be backwards. And I'm just shimmying this a little bit off to the side here because I want to be as close to this edge as possible on this pouch. The reason for that is if I'm as close to this side as possible, that's going to bring this entire pouch this way, so that'll give me room to pouch her stoma separate. Okay, so I'm coming back here, I'm gonna take this template and I'm tracing the shape onto my pouch. Just like this. All right, so now there's this little starter hole. I'm making sure that I hold my plastic out, taking my scissor, putting my scissor in through this little starter hole. I'm using the bandage scissors that has this little blunt end so that I don't pierce the bag. And I'm cutting this real quick. You don't have to do it quick, but you can cut it accurately. How's that? Cutting it all the way, making sure that I'm not outside my line. Okay, here we go. Great. Okay, so I have my shape, and you can see here we are. We're right within the shape of that wound. That looks good. I like to make sure that I'm just a little bit bigger and that I don't see any black on my tracing. So I'm just going to trim this just a little bit more, but you get the idea. Making sure that I'm not touching the wound, because obviously these wound manager pouches will not stick to the wound bed. Okay, so that looks pretty good. The next thing I'm going to do is, again, we want to bring this drain outside of the pouch. So a lot of people are asking, how the heck do I use the catheter access port? So the catheter access port is meant for this very reason. It allows you to bring a drain out through the bag. So a couple parts and pieces here. There's this blue piercing pin, which looks like this, and you can see at the very base of it, it has this little plastic piece. So now that you've cut your big hole, you have the ability to kind of come in through this way, and you want to think about where that drain is. So the drain is kind of near the bottom, and we know that our pouch is going to sit here, so I'm going to want my drain to come out from this pouch right about here. So I'm not adding too much pressure, but I'm just adding enough pressure. I have my thumb in through that blue piercing pin. I'm bringing the plastic, which might be hard to see, right over where this little clear plastic hub is. Then I take the second piece, which looks like this little witch's hat, and this snaps onto that other opposing plastic piece. I can kind of hear a snap, but I'm using my strength to really push those two parts together, and now you can take that blue piercing pin out. Just like that. And it is sharp, so you might want to put that in the sharps because you don't want that to pierce the trash bag and all the other reasons. So now you have this little witch's hat here, and you can see that there's different levels that you could trim it to bring this drain out. I don't like to trim it too large because then there'll be a big gap, but I think roughly we'll start with that. And when I look at this, obviously this last end of the hub here is pretty big, and this stem piece is a little skinnier. So I'm gonna go just a little bit bigger. And I have tweezers here to help me bring this drain out through the catheter access port. Okay, now that I have this done, what I'm going to do now is I'm gonna take the plastic pieces, or plastic piece off of the back of this wound manager pouch. And in order to get a good seal, typically what I like to do is I like to take my barrier rings, and in this case I might need around 4. I warm them up in my hand. That's what makes them really pliable. And I'm just going to line the entire edge of where I cut. I'm opening this up so I can get the most length out of it. And I'm just sticking it to the edge. Obviously, I'm trying to do this quickly for purposes of the video, but you get the idea. In real life, you might want to take a little more time to warm these up in your hand, or you can have the patient warm up a couple as well, or your friend who's helping you. So stretching this, again, as much as you can, because we want to run the length of this wound manager pouch. There we go. Okay. And then I usually will kind of, just like a pie crust, I kind of pinch all the way along the back. And again, I'm doing this a little bit quick just in the interest of time. It's probably not as perfect as what I would like in real life, but you get the idea. Okay. So you should have an end product that looks a little bit something like this here. You've got your barrier ring all the way around the edge. Okay. So now what we're going to do is we're going to very carefully, and this drain is not necessarily sutured in, so you do want to be careful not to tug it. This is going right into the enteroatmospheric fistula, which looks a little bit like this. So this is the patient's, obviously you can't see here, this is just a model, but she has a little stoma, or a piece of bowel that the tube is going into to help bring some of the stool out through the wound and out of the pouching system. So this actually went in okay. I'm making sure that I don't have any tension on the insertion site here. I'm bringing this drain through the bag, lowering the pouch down around the wound, and I'm ensuring that I'm lining everything up perfectly. So there you go, lots of good pressure around there. Then I usually take waterproof tape, and in this case, I'll just use a Tegaderm. And I'm just going to go, there's going to be some air here, so I'm going to just make sure that that's very well secured. And you could just use maybe some foam tape too, or any other waterproof tape. So go right around that junction so that it's nice and secure. Just like that. I'll just take a little bit of tape here just for good measure. We'll make sure everything is nice and secured there. And then the provider has ordered for this tube here to be to suction. So this is to wall suction. This all looks really good. Okay, so now we move over to our stoma. In this patient's case, there's a little bit of a skin crease here. So what I tend to do is I fill any skin creases with my barrier ring. So she's got a crease at 9 and 3, little tension creases. So we're just gonna fill the skin creases. again, you get the idea. And this patient likes this pouch. This is a soft convex, deep convex pouch because her stoma isn't very big. And I'm gonna go ahead and cut this to size. I know that her stoma is just about 1 1/4, so I'm cutting that. Again, just in the interest of time, I'll be quick with this, cutting this to 1 1/4. When I cut bags, I like to put my thumb in there just so I know that I'm not cutting the plastic part, if you're wondering why I'm doing that. It's just been my practice so that I don't pierce the bag. Okay, so I have that cut. I'm going to take the plastic part off of here and add a barrier ring on the back. Again, I'm doing all this because this stoma is a little bit flush or flat, and she has those skin creases. Okay, so I'm putting the barrier ring on the back. And she has less output coming from her stoma compared to the wound, so that's why I typically will pouch the area that's draining the most. So my primary focus is on getting this fistula pouch on, and then my secondary concern is the stoma. So I have that all set and ready to go, and I'm placing this over the stoma. And I'm just moving, you can see that I'm moving this plastic of the wound manager pouch over, and I'm actually sticking, if you want to get a close-up, sticking this pouch right onto that edge or the barrier of the wound manager pouch. And you can see over here as well. So that looks like a really good seal. The next step I take, and I won't do the entire edges, but I'll just show you the highlights. I've cut all of these duoderms in thirds, is what I typically do to prep. So I will go all the way around the edge of the wound manager pouch for extra security, just like this, all the way around. So you get the idea there, all the way around. Okay, so I would do that completely around there, and then I want to show you exactly what I do here at this junction. So this is where the pouch meets the wound manager pouch, very important. I will typically take the duoderm, or sorry, hydrocolloid, and I will actually place it down over the belt loops for a little extra compression at the 9 o'clock and 3 o'clock position, just like that. I do the same thing on this side, except this piece is going to be a little bit skinnier. And this will just make sure that there's a little bit of compression and a little extra security so it doesn't buckle. I don't know if you can get a close-up of that. So this is exactly what I've been doing, putting a little bit of barrier ring right over the belt loop. Okay, so that looks like a really good seal. And of course, we're gonna fold that up. Okay, so now to the portion where we put the wound manager pouch to suction. So again, she has a wounded area. The drain is sitting within the enteroatmospheric fistula. This is draining like 1,000 cc's of fluid every 24 hours or more. It's watery. She's on a full liquid diet, so it's mostly liquid coming into this fistula and into the pouch. So what we're going to do next, I'm going to show you how to fenestrate the tubing. So we're going to create what's called a suction pouch. So this is pretty accessible. This is just nasogastric tubing that's on most of the units. What I do is I fenestrate the tubing, and I'm going to snake it up through the bottom of the wound manager pouch. I'm going to cut this top off here. This is going to go to your wall section as usual, this end. And this is the important part. So I'm just taking my scissor, I'm going all around the tubing. Of course, if you have a pre-manufactured fenestrated tubing, I would, definitely use that. Different WOCNs will do some different things, but you get the idea. I kind of consider how long and where I want this tubing. I ultimately want this to not be in the wound to cause trauma. I just want it to be sitting outside and sitting on the actual material. So I'm gonna go down and make just a couple more holes right to about where my finger is. And as you can see, I'm kind of alternating sides. So I want the holes to be on both sides of the tube. Okay, so that looks pretty good. Let's just kind of straighten it out. This is now going into the bottom here of the wound manager pouch. I'm snaking it up through the bottom. I'm not quite connected to suction yet, because if I connect to suction now, it's gonna be harder for me to advance this catheter. So I'm gonna leave it off of suction for right now. And I'm gonna put it exactly where I want it. So I want it, if you wanna get a close-up of this, I want this to be right about here. So it's not in the wound, but it is directly on top of the material, just inferior to where the edge of that pouch is cut. So that's where I want it. So in order to get a good seal when you turn your suction on, and I don't have a suction source in this demo room, but I take a barrier ring. This just makes sure that there's a really good seal, and I cut it, or break it really, in half, and I take this and I bring it all the way around the tubing and the end of this spigot, just like that. And this just helps to ensure that there's a really good seal around everything. And then I'll just take some waterproof tape. I'll make sure that my wall suction canister is well marked. Okay, and then I turn my suction on. And then what you'll find, again, I don't have a suction source in here, but what you'll find is when the suction turns on, because all of your junctions are well secured, this pouch is going to suck in. As her fistula is outputting a stool from the little pseudostoma that she has in the base of the wound, this suction tubing is going to siphon off all that drainage, and it's going to keep the patient nice and dry. Typically, I'll set the wall suction. Obviously, we have provider orders for all of this. The wall suction would be set at about 30 millimeters of mercury, just very low suction. We don't want to cause any trauma. And we have this tube is usually secured with a little securement device over here, and certainly you could secure this tubing as well. The patient could be connected to a portable suction when he or she gets up to ambulate. And that's it.